everyone. Good afternoon. Since we've just switched over to live, we're letting the participant list populate before we move forward. So just another minute or so before we begin. Thanks for being with us. All right, so it looks like our participant list is populated. Excited, we have 70, oops, still going up a little bit, over 70 people, so welcome. My name is Molly McGarrick, I'm the secretary for DHSS. I know many of the folks on the line, you are our valued partners, so we're very excited to have this conversation today to talk about the update on our rate methodology work that was kicked off by Epilogue a couple years ago. This was the next phase of it that we talked about in August with the creation of the roadmap that we're going to have Mark here to discuss today. He's our subject matter expert and has done this work in many other states. So we continue to be very grateful that he's been able to support our continued path forward on this important work. So Michelle, if you could go to the next slide, going to walk through the agenda for today. So these are the introductions. Hello. We have other members of my leadership team on, and Mark Podrasik, who's going to go through the meat of the presentation. We're going to go through the review of the rate development terminology, overview of the key activities in rate development, the proposed roadmap for the DHSS rate development work, obviously key questions to think about as we move forward with this work, as well as the toolkit for, again, what are next steps from this work. For those that have questions during the presentation, if you could please put those in the chat box. We do have a large number of people, and we don't unfortunately have probably enough time to get through all of the questions. We're going to do as many as we can. But again, in the interest of time, we're going to have Kiki Evinger and Michelle Stant help moderate, and they will be asking your questions from the chat box. And we will have information at the end about where you can submit any feedback that you have. If you're not able to answer a question, or if you think of other questions after the presentation's over, at the end of the slide deck, we will put Michelle's contact information. She's volunteered as tribute to get the questions from folks, as well as the important feedback we know you all will have. So with that, thank you again for joining us. Happy to have you all with us as we continue along this journey, and I will turn it over to Mark.
Thank you, Secretary. Let me see. I'm going to share my screen, and if somebody could nod, they see my title card. Okay, thank you. So just as an introduction, this phase of the work that myself and my team were asked to do for the department is really to help frame how, from a long-term perspective over many years, can the department think of all the different services for which it's paying for services, and understanding that many of the different providers on this call and others are reimbursed in different ways by the different divisions, and that's for good reason, based upon different methodologies that have been created that are unique to those service categories in particular. Recognizing that there's at the moment not a kind of a full work plan of all those services combined. So we were asked to help develop what we're calling a roadmap that identifies all the different considerations that need to be put in place. So therefore, what this is not today is kind of a result of the actual doing the work of the rebases. It's more how to go about doing the rebases themselves. The Secretary identified the topics already, so I'll skip over that, because we do want to make sure that there's plenty of time here in today's session for the questions. So the presentation here will be up on the website for your consumption to look at in more detail after today. So I apologize in advance if I go rather quickly through the first half here, just because we do want to make sure that we have time for questions and feedback. But we did deliver, we have engaged with the department, and there was a report that was delivered back in May of 2020 that went through the universe of all the different services, and we created dashboard reports across 20 specific Medicaid service categories. And we also identified some dashboard reports for services that are not paid on a fee-for-service basis, but more on a per contract basis. And you can see the acronyms of the divisions outside of Medicaid or DDDS or DSAPID or DSAM. The report is here at this link, and there were 9 recommendations in that report. The first and most important one was for the department to create a roadmap. So that's what today is about. Since that report was delivered, there was an additional epilogue language, which you can see this is copied verbatim from the epilogue, but it basically says create the roadmap, department, and here's the specific items that it's asking for, what resources are needed, is there a Medicare equivalent methodology, and what are those rates, what do other states pay for these services, how do you engage with stakeholders, etc. So we're going to use I'm going to use the term rate rebase and rate update throughout the presentation. So on this kind of list definitions slide, if you will, those are the most 2 important things to focus on. And when we talk about a rate rebase, that's what I would call the more involved process. It often includes collecting actual costs from the providers that are rendering the services. They don't happen as often as a rate update can happen, but nonetheless, it's kind of the wholesale scope of work in looking at setting rates. And so we've developed 12 unique steps to go through, and I'm going to walk through those in this presentation. It is important to note that rate rebases can occur with no aggregate change in payments. It could be an increase, it could be a decrease, it could be an increase in some components and a decrease in others. I mean, it's every combination, and in the 20-some state Medicaid agencies I've worked for, I've dealt with all of those issues. I mean, going out of the gate, sometimes the state says to us, we want a rate rebase, and we're ready to put some additional money in. Other states say to me, we want to do a methodology update, but at the moment we don't have any additional funds, but we at least want to have the infrastructure ready so when and if there are additional funds, we're ready to move forward quickly on those. A rate update, to contrast with that, would be less involved. Oftentimes it's just saying we, the state, accept the methodology in place to pay for this service, but we're just doing whatever update is necessary on a more regular cadence that might be necessary. For example, if a state is keying off of a Medicare methodology, whether to pay physicians or home health or things like that. It could be that if you're keying off the Medicare methodology and CMS releases updates, the state wants to then mimic and follow those methodologies as well. So that's what we're going to be referred to throughout this presentation as a rate update. One of the things that's important to both processes is we always recommend that a state uses a most current period of time for utilization, which is up here defined as the count of the services rendered. So often we recommend a 12-month period. With the pandemic of late, we've been recommending to states look at more like CY 2019, pre-pandemic, because 2020 is such an odd year. But certainly to look at what was the payments made for the utilization for that 12-month period, and then if there's a rate update or a full rebase with new rates, reprice everything for that same utilization under the new method and see where there's dollar changes in the aggregate or individual providers. So I'm not going to read this slide, just to let you know there are 12 steps coming up, and we'll go through each one in detail. The first step that we believe when we're talking about a full rate rebase is to actually review the service definitions or specifications. In my view, this is most important for those services that are delivered in the community or the home and community-based services in particular. Why? Because each state often, although they might be using common CPT or HCPCS codes for billing, the service definition under the hood can be quite different across states, as opposed to the standard CPT codes when you see in acute care, whether it be for the professional services like physicians or therapies or medical equipment, et cetera. Those have a national definition. And the reason why it's important is particularly when we're looking at those HCBS or often called the waiver services is that many states will indicate the staffing assumptions in the service definition. This service must be delivered by such and such licensed professional, or there must be X number of staff per participants, if it's something like a service for individuals with IDD. So we want to make sure that we understand exactly what those service definitions are, because that's going to help us get to the costs to the provider. We always believe in conducting kind of a kickoff meeting, if you will, or an orientation to stakeholders about what's coming up ahead, how long do we think the process is going to take, where we would like providers to be participating, where we know you're going to be participating, and what the end result, if it is known upfront, will be. Because of the rebases, as I alluded to, we want to collect cost information. For some services, that's relatively straightforward because the providers are already subject to submitting a cost report to CMS. So whether it be hospitals or nursing homes or home health agencies. For others, particularly those HCBS services, we often will develop a customized survey for the state based upon the services that they are interested in collecting costs on, because there's no national standardized form for that. While the survey is out in the field collecting the information from providers, we also recommend that other benchmark information be collected as well. The most common example that I have run into would be a HCBS service where it's a rate that has been in place for a very long time and is probably ripe for a rate increase. And maybe the underlying assumption in the current rate that's being paid presumes, say, an hourly wage for a direct service professional of $9.50 an hour. But the going market rate, using Bureau of Labor Statistics, other states nearby, just general competition against other labor forces, whether that be Walmart and Target or other like services, maybe that's calling for the average wage in the Wilmington area is $13 an hour. So if we just collect the provider's costs, they're probably paying closer to the $9.50 because that's what the provider's being reimbursed. And that would just be, self-fulfilling, that we would always be circling back to $9.50 an hour when we know that there's another example or benchmark out there of a different value. So we kind of join the two data points together in step 5 here, and we compare and contrast what are providers reporting are their costs versus what are these other benchmark information sources telling us as well. Where are they similar? Where are they quite different, and why? So from this joint information, whether it be the provider's costs or benchmark information, we build the rates. One guiding principle that we always recommend to states is that the cost should be covering what would be an economically efficient provider. So therefore, we don't want to undercut the costs that the providers are going to bear, but that doesn't necessarily mean that we're cost settling either. So, in many methodologies, not all, it's a law of averages. Some providers right in the middle will do fine and get their costs covered. Some that are more efficient will actually have a little reserve because the rate takes care of their costs and then some, and others may not do as well. That does not always have to be the case. Each state has different policy decisions. Sometimes it's access to the service is most important, and that has a higher weight, if you will, than the economic efficient standard. But nonetheless, that's just something to keep in mind as we're building rate methodologies. I already mentioned this, use recent utilization to measure what was paid versus what could be paid under the new rates. That's what step 7 is telling us. And then present that initial look to the stakeholders. And when I say stakeholders, I take a broad definition. So clearly the providers that are impacted by the rates are the first stop and the most important stop, but it could be legislators, other advocates for that service, other state agencies that may also deliver the service or be impacted by the rate paid from one division to another. We suggest we show, here's what the payments would be if the state could afford the full boat rate, if you will. We call that the benchmark versus, okay, well, given the current financial constraints, if we backed down from the benchmark and this is what we adopted, here's what the fiscal impact would be using the adopted rate. So I'm aware in conversations with different divisions that this approach has been used with some of the providers, probably some on this call in relatively recent years. That's an approach that we agree with as well. Number one, it lets everybody know in a transparent way what the delta might be between what the aspirational rate is and what the adopted rate is. And it also just helps to explain where the difference is versus it being kind of in a vacuum. Step 9 is always important in that, particularly if it's a rate rebase and it's a fundamental shift in how the payments are made, the fiscal agent or the claims processors or the managed care organizations obviously need the lead time to understand how they need to program that, because in many states I've worked in, the provider's number one concern is, yes, I want to know what my rate is, but more importantly, am I going to get paid on time? And without having all that systems work in place, that's where some states have run into jeopardy. We do believe and recommend in step 10 that there's a public comment process. So you'll notice this is towards the end of the 12 steps. There have been these meetings with providers and other stakeholders along the way. We're not recommending that the public comment process is the first time providers see the rates. Really, this is more of a formality in case there is anybody that has not been participating. The state is conveying its intentions and policy decisions through the public comment process. And then after that process is finished, to finalize the rates based on any feedback, and if there's any policy decisions or adjustments the state wants to make from that process, you finalize everything here in step 11. And then in many cases in step 12, particularly for the Medicaid services, the state needs to get federal approval. Otherwise, the state's not going to get the federal match on the payments that are being made for that. So I realized I did those steps quite rapidly because, again, I wanted to make sure there was time for feedback and comments. And I'm going to open up in a moment and ask Kiki to let me know if there's anything. But here we just wanted to walk through. I'm not going to read all this to you, and you do not need to follow everything other than to say, if it's a rate rebase project, those more elongated projects, it could be as much as 24 months in duration. The first 6 months in my example, I've got it broken up between 6 months and then 12 months and then another 6 months. The first 6 months is kind of the preparation period. Let's get ready. Let's let stakeholders know this is coming. The state might need subject matter expertise that's not currently at the state. They might need to release an RFP, those types of things. The next 12 months, I'm just identifying the 12 steps I just mentioned and the cadence and how they might be followed. Certainly not every project follows this exact timeline, but this is an illustration of one that could happen in this way. And then the last 6 months is really finalizing, getting the systems, things set up, getting the federal approval for a go live of Jan 1. So again, not every project needs to be this long, but some projects could be. In my experience, the thing that holds it up is either the systems piece or the federal approval. As long as states are working with their providers in a collegial way throughout the process, yes, there's always back and forth, and no one's should underestimate that. But that doesn't seem to be where the challenge is on the timing. It's more the back end stuff like the systems and the CMS approval. So any questions in the chat box? Let me pause there, and Kiki or somebody else, is there anything I should be addressing at this point?
All right, so right now, the first question that has come up is how do the MCOs fit into this review process?
At this point, they do not, because this is more of a policies and procedures exercise, if you will. But I have already noted to the state staff that my experience has been that even in states where managed care is the predominant delivery system in the Medicaid programs, that states should not ignore the fee-for-service rates, even though they're not actually often used in real time. If you're 90% managed care, for example, that's where all the participants are. But many MCOs are keying off of the fee-for-service rates as their benchmark. So if a state does not maintain its fee-for-service rate schedule on a regular cadence, that can get the managed care rates also out of sync, if you will.
Thank you. And then we have one other that has come in so far, which is about when does all of this take place?
So I'm not sure exactly when they say the what, but we will be sharing a illustration of a sample roadmap of the timing of when certain services could follow in a multi-year period. And so maybe you can ask another question when we get to that slide.
Sure, and I'll just step in really quick. So
Sure.
I do think it, and Mark, you made this point, but I think it's really good to call out that like we've seen with the IDD rates, there's a methodology that was created. We went through a rate update at the end of 2019. We have benchmark rates. That's really what we're talking about and what the epilogue envisioned for more of DHSS services. We have it for some, we don't have it for others. There was some understandable frustration on the part of the JFC co-chairs as to why like childcare rates have a market rate study that's created by the federal government. There's a 3-year cadence we have to follow. Again, the IDD services have a very robust and developed rate methodology and process for how any additional funding gets distributed and trying to target providers who are farthest away from the benchmark. That does not exist now for all of our services. So again, that was really the genesis of this project, was can DHSS undertake an effort to have more of this transparency and predictability around what happens if the JFC gives us $1. How would we distribute it? How can we guarantee that it's equitable? How are we taking into account external factors, like Mark mentioned, such as what's the minimum wage and what's the prevailing wage for some of the employers in the area, where these workers would go if they don't do this important work. So there's not necessarily set timelines for all of this. We're just continuing to build the processes around it. And again, some of these rates we already have. The other piece, which is really difficult and I know has been a constant source of frustration, is just because we developed this does not mean that the JFC or the state of Delaware has the funding to get everybody to 100% of a benchmark rate or even 80% of a benchmark rate. So we are doing this work, and this is important work to build the architecture of rates and how we distribute funding. But just because these rates get updated does not mean that DHSS is necessarily set to receive additional money to pay for getting to a higher level of a benchmark rate, whether it's 100% or otherwise. So this is a process that it's not happening in a vacuum, but it's not something that's going to automatically mean that there's more money on the table. That is something that, again, the governor put out his recommended budget. We're about to begin JFC hearings. We don't know what the financial picture is going to continue to look like with the pandemic, but we are getting this architecture in place so that from now to the foreseeable future, we can provide greater transparency and perhaps a cadence that will give some predictability to providers around when we will revisit rates for updates versus rebases.
Thank you. Looks like I'm not seeing any additional questions at this time. So Mark, if you're ready for the next phase.
Okay, I'll proceed. So those 12 steps I just went through falls under the purview of the terminology I'm using, the rate rebase. This slide is just to let you know that when we're using the term rate update, again, may not be as involved. And when we think of the rate update, it's the last 6 of the 12 steps. So again, very quickly, we still want to look at recent utilization in step 7. We want to present results to stakeholders on whatever the update is. For example, CMS released an updated physician fee schedule. Here's how it impacts providers in Delaware Medicaid. Then it could be that maybe a new modifier got added or some other policy change was implemented by CMS and the department says, yes, we want to adopt that as well to be in sync with them. So there's system updates that need to happen. We still recommend a public comment process, even if it's the less involved rate updates. And then obviously the finalizing of the rates. And sometimes not as much, always every single case, CMS approval is needed. Again, if it's just following the same methodology and the state plan already says, we're going to follow this methodology and we're going to follow Medicare's updates, then you don't need CMS approval because you've already the first time you saw permission. Other times you need specific permissions. So here's an example, as the secretary was alluding to. Example 1, the legislature appropriated $1 million in funding for blank service. Okay, well, absent the background information, is it an across the board increase for every service in that category? Or maybe not every service is at 100% of the benchmark, but some were at 90%, and a few were down at 50% for some reason. Well, that would probably imply that a targeted increase, the first dollar out should go to those at the 50% of the benchmark to get them at least up to the 90% to be with all the other services, as opposed to giving those at 90 up to 95. So that's one example of why having the tangible information readily available at hand to help answer those questions more quickly, because legislators often want to know those things very quickly after they ask the question. And then example 2 is the one I was just citing. Delaware's keying off of a Medicare fee schedule, and Medicare came out in its public notice and said, this happened on the professional fee schedule. In my experience over the last 10 years, 1 year, they purposely said, we're going to cut the radiology rates. Another year said, we're purposely increasing the evaluation and management rates. Another year, they said, we're going to remap behavioral health codes and make some changes there. So all those things obviously have implications to Medicaid as well. So how should that be examined in a rate update? So here's just an illustration. Again, a rate update. Notice it's not 24 circles, it's only 6, because maybe it's something like, sometimes these things only take a month, right? I mean, if it's a relatively straightforward methodology and everyone understands the ground rules, it's just reading in the new rate file and modeling the utilization. Other times it could be a little more involved, particularly if it's those systems changes. So this example predicates a 6-month process. It could be shorter. And then here's the example of, updating the Medicare fee schedule. The first one, was more about the legislative appropriation. If the legislature finishes its work June 30, which I realize in many states that's often the case, you find out on June 30 the final decisions, and you kind of work your way to an October 1 rate increase. It can't happen automatically July 1 necessarily. Whereas the second example, if you're keying off a Medicare fee schedule, maybe, CMS releases this information. I just made up July. Oftentimes it's October when they do that. And then you go through the processes 7 through 12 to go for a Jan 1 rate change for implementation. So this is all kind of the exposition of what we're trying to help the department with, just laying that groundwork and what should be a common approach, recognizing that different methodologies have often very unique specifications around them for good reason, in my opinion. But that doesn't mean that those steps that I just described cannot be common to pretty much any rate rebase project or rate update project. So the roadmap itself that we are sharing today gives an illustration, and it assumes like a 4-year period, meaning that it really is probably not feasible that the department can undertake a rate rebase on every single service category every single year. And quite honestly, as a consultant who works with a lot of states, I wouldn't recommend that anyway, because you're just constantly chasing the tail. Whereas if you kind of lay out a framework and then there is a regular cadence, and in some states I've worked in, the state even declares in its state plan for CMS approval, this is the service category, and we will conduct a rate rebase at least once every X years, and the state picks that time period. So I think of services in three categories at a high level. One is services, they never need the full rebase. Why? Because the state is keying off of the Medicare fee schedules. These would be services that it's certainly possible to collect the individual provider's costs, but let's say physicians is a good example. Well, if there's 8,000 physicians to survey, that's an awful lot of surveys to collect and intake and read in. And we don't know, I mean, there's such a variation across physicians themselves on why their costs could be different. Whereas CMS, fortuitously, does a lot of that work on their own using the relative value units. So it's just more expeditious for states to key off of Medicare. They may not be able to afford the full Medicare rate, but at least they're using that methodology. So in those cases, the full rebase is really never necessary, but that doesn't mean that it's more likely the rate update would occur as much as annually, because that's when CMS is updating. Others fall into the category of the rate rebase. A common convention we have lived with states and often recommend is something like once every 4 years. But even when the rate rebase occurs, as the secretary was saying, we still want to preserve the update. In other words, we want to get the latest provider costs. We want to understand other dynamics that's going on in the industry and the service delivery. So even if there's no new money to go in, that doesn't mean you don't do the rate rebase, because for no other reason, if the benchmark was at a certain point and now costs have gone up, we need to change the benchmark and raise it to a higher number so that there's awareness and transparency that the benchmark is now higher. And if there's no new money, that just means that the delta between the adopted rate and the benchmark is much wider, but at least there's an awareness of what that delta is. And then oftentimes we see the combination. So it's services that should be under a regular rebase once every X number of years, but then you have that relatively recent information. The legislature said in my example, we have another $1 million or $2 million to spend. Okay, department, where specifically should we be spending this within this service category? There's information on the shelf to do that analysis relatively quickly without having to go through a rebase every single time. So the recommended guidelines, if the service is only subject to a rate update, do it every year. If it's subject to a rate rebase, do it once every 4 years. And then there could be other things, and that's really more at the discretion of the legislature and the appropriation. Say you do a rebase in year 1, but then the rate update could be in year 2, year 3, year 4, or all 3 even, depending on the appropriations. So that's how we're dividing the roadmap, as you'll see, and we're creating service categories and assigning them to rate rebase, rate update, or potentially in a few circumstances, even both. There has been some consideration of DHSS resources and not doing everything in 1 year. Please consider what you're going to see in example illustration. Part of the reason for the presentation today is to get feedback on the construct of the roadmap, not necessarily assigning which service goes in which year or which cycle, but understand that this is really more for illustrative purposes. So let me walk you through how this page is constructed. It's only 1 page. The upper box, which is in green, represents those service categories that are subject to a rate update and not the full rate rebase. If you see an asterisk after the service category name, that means that most likely DMMA, Medicaid, is already keying off the Medicare fee schedule. There are some that DMMA is not necessarily keying off the Medicare fee schedule exactly, but nonetheless are doing an annual update. So here's all the services down the line. And the color coding is just to have them all stand out by themselves. There's no, don't infer anything, right? The fact that some are yellow and some are white and some are brown. But you can see professional services like the physician fee schedule. That's what we mean down here: physicians, nurses, and therapists, dental services, lab and radiology, hospice, dialysis, ambulance, medical equipment and supplies, home health, nursing facility, and assisted living. So one big caveat here is that DMMA, in my interviews with them, says that they look at those every year for an update. But again, as you all are well aware, the final decision is subject to the financial resources available to DMMA to make the change if there is a change. But that doesn't mean they're not looked at and considered. So that's what we're saying here. Each of these services should be considered for a rate update every year. That doesn't mean there's a guarantee there's going to be an increase, but at least it's looked at. The blue section are those services that we are recommending should get the full process of a rate rebase once every 4 years. And that the implication there is that all of these services, the department should be collecting cost data from providers to at least inform the process, as well as having a more elongated and extensive feedback process with the providers themselves. So again, the main rationale around the categories of what we're calling cycle 1, 2, 3, and 4, number one was resources across the department, but also was to try and find services that are related to each other in some situations. So the top section of the blue in each of the cycles is really some type of waiver services. So you can see we're starting out with substance use disorder, which, by the way, is actually ongoing at the moment, followed by behavioral health, and then IDD, and then other community-based services for the elderly and physically disabled population. So you can see from this array in this top group, we're trying to at least cover all of the significant waiver services across all the major populations that are served by the services that are paid under those methodologies. Then below that, we often bring in some of the services that are more the responsibility of Medicaid, DMMA. So that could, in this first year, clinics. Then we move to the IMDs, and that's partly related to, because we're already looking at behavioral health in this same cycle. And then other inpatient hospital acute care. And then the next cycle is outpatient hospital acute care, and ambulatory surgical centers are related services. So they're kind of done in tandem. And then because we're dealing with the waiver services for folks in home and the community for the elderly and physically disabled, we thought the home health agencies, and then the more institutional services like nursing facilities or even assisted living. So again, this is just a way to kind of frame the thought process. Personally, I don't have a strong opinion that something should be in one cycle versus another. It's just a way to display it. And I don't want to forget that childcare is also on the list, which is also happening actually at the moment as well. So this particular roadmap does not predicate the start date per se of when everything is going to begin. And it also doesn't assume that this is the actual order and sequencing of them, but it's just more of a framework again about that every service gets attention every X number of years. So I'll pause there. I don't know whether if the secretary had any
Yep.
specific comments on this.
Yep. So I want to be clear, this is not something that we are saying. This is absolutely what we're doing. As you'll note, hopefully at the top of the presentation, it says example. We absolutely want feedback on this, including order, etc. As Mark said, we did it to also acknowledge that we just as a department cannot do all of this in 1 year. And also some of the services, and I heard on a Zoom last week with one of our provider partners that they're like, our rate actually it's pretty straightforward. So we don't know that we need a full rate rebase. So we think, a rate update could be done pretty quickly. And again, that's what we tried to show with this, is that everybody does not have to go through everyone likely does not have to go through a full rebase right away. For a lot of our rates, a simple air quotes, still not simple, but a simple update would do. And then this directly addresses something that, again, we heard from the JFC co-chairs at the time when the original epilogue was written. And we hear from providers that the lack of predictability of when their rate is going to get looked at is just frustrating, confusing. Pick your adjective. They're all valid. And so this was meant to inject a level of predictability and a level of transparency, and also acknowledge the fact that the department cannot do a rebase every year. And frankly, a rebase really isn't needed every year. So trying to get on a calendar and a cadence so that we can align contracts, we can set up our workforce, the providers can work with us, because as you saw in the other 12-step process that Mark laid out, I mean, we need providers to engage. We do not want to be creating these processes in a vacuum. And we understand that the providers are busy too. And so to just drop everything and be looking at all of these rates in 1 year is not feasible. So again, this is an attempt to address the original intent of the epilogue, which is to provide some predictability and transparency to both providers and the legislators. And it's also to set out a cadence that is realistic about the department resources, and what we've understood from providers are going to be their resource limitations as well, to be able to fully engage in the process of both updates and rebases. And Michelle, did you have anything you wanted to add, or anyone else on my team?
No, I am monitoring the chat, and I think there's a couple comments that I at least want to highlight. And Mark, you might want to, I think in some points you might address them later on in the presentation so we can get there. But very closely tied together are workforce stability, especially where there is already a rate methodology. And where we have that concerns about workforce stability, and especially then how that ties to potential minimum wage bills. So I don't know if you want to discuss that now or if you want to wait.
I can comment for a moment, and if the answer is not satisfactory, somebody can ask a more pointed question. Our experience as rate setters is as follows. When we do a rate rebase, we are trying to take the long view of where wages in particular are heading for the service that's being rendered. Probably the most critical and influential impact to rates is home and community-based services and the direct service professional. I mean, in our world, when we're setting rates, if the benchmark rate doesn't reflect the realities of what it takes to cover the wages and benefits of that staff level, because it's such the predominant staff level, you're going to completely miss the boat on. I mean, you can have everything else covered, the buildings and the vehicles and all that, but if 60 to 70% of the costs are borne by the wages and benefits of those folks, and the lower level folks are really the frontline workers, you're going to miss the whole thing if you don't pay attention to that. So we think that's part of any rebase project. In non-rebase years, there can certainly be analytics done, even if the rate itself or the methodology is not being updated to compare, well, if the minimum wage went from X to Y, or if just the economy is going to get better again, and the market rate to pay a direct service professional is going from X to Y, can we quantify how much cost that's going to be? How much would the rate need to go up, even if the rest of the rate was not rebased, just that one component? So that's why we believe that having the infrastructure in place with all those tools readily available, whenever we do these, we just drop them in Excel. The state staff can plug in a new hourly wage, see what the new rate is, multiply it across, and get a number pretty expeditiously, at least as a back of the envelope estimate. So I do believe that you can be looking at things even in non-rate rebase years to address the cost, particularly on the staffing side.
Thank you. And then there was another question related to how our outside revenue streams, I think it specifically was related to considered in the budgeting process. And I will say that we certainly don't want to speak for our colleagues in the legislature or at OMB about whether or not that's part of the budgeting conversation. But since we are talking rate methodologies, how are outside revenue streams, such as private pay, in a variety of number revenue ways, how is that considered when looking at rate setting?
So that's a very good question. I will tell you that I try and be agnostic to other rate revenue sources whenever I'm setting rates, unless my client is saying you must consider it. There are a few states, and I have actually set these rates, albeit a very long time ago, where the state actually had a provision that said, this is the rate we're going to pay for this service, but if you get X amount more from non-state revenue sources, they would cut the rate back. Now, that's a pretty draconian view of setting rates. I'm a purist. If I want to set a rate, I want to know what the costs are to deliver the service, and the financial means of the payer, whether that be the state, a commercial insurer, Medicare, whomever, that's like, it's obviously related, but that to me, that's a separate conversation. The first step is just, what could the rate be if finances was not a concern? It always is the number one concern, but I want to look at the rate development first without letting other revenues influence the rate setting process.
Thank you. And then there's a question about, is the intent to make the rebase for hospital acute care services budget neutral?
Well, I guess the first question is, I don't know. I mean, because this is just an example of the roadmap, I don't even know when and if those services are going to go under a rebase. And thus far, I certainly have not been told. I don't think anybody in this call knows the answer to the question about the budget neutral question, if and when the rates even do get rebased, particularly because we don't know when it's going to occur. Secretary, I don't know if you.
Yeah, I was going to say, I think this is a really good, again, reminder. We are looking for feedback. So that is a perfect example of something that we would love to see. And again, we'll have a slide at the end where people will send their responses to Michelle Stant. But I think, again, all of that is on the table and up for consideration. This was the key. This roadmap was the key next step in this rate methodology journey. So there are no hard and fast decisions that have been made. We're bringing this to you all as key stakeholders. We're seeking feedback, and then we will create a report that will get submitted. Michelle, what's the dates? I should know this, but I'm going to blame COVID. Not that I have it. Just the pandemic.
Imminently. So this is part of the process of getting the report submitted, and we are looking to get feedback this month from the stakeholders. So please send them my way. And then we'll be wrapping everything up with Mark and his team over the next month and submit something formally in March.
Yeah, so really kind of where this fits in is that if the legislature gives more money, we want to be able to say this is how we would spend it. This is the process, this is the benchmark. And then similarly, we want to in the future have data that people, when the legislature is saying I have an extra dollar, they would have a set of rates that have either been updated or rebased so that they could say, wow, this group is only at 40% of their benchmark. This is critical. That's appalling. We want to put X number of dollars towards it to get them to a higher level. That's really what we're working. This is not meant to, again, and I see a question, like if the rate's already been looked at, what's the timeline for a rate increase? That is unfortunately, and I'm not trying to punt or kind of be like, that's above my pay grade. But I mean, those are decisions for the legislature and the Joint Finance Committee to put forward. This was to answer questions and frustration by the JFC and saying when they appropriate money to DHSS, it's sort of not a transparent process about how it gets spent. They're confident and they like how the IDD rates work, where there's benchmarks. Same thing with childcare. There's a benchmark. We know how far away we are from it. When they appropriate funding, they have a better sense of it's going to go to raise the level. That doesn't exist for a lot of the provider contracts and the other services we pay for. So we're working to quick catch up and have it in place. So if and when there's more money available, again, it's transparent to providers, it's transparent to legislators, it's transparent to the public about how we're going to use the appropriated dollars.
There is another question in the Q&A, and I think Mark's actually going to address it in the next phase, so I'm going to hold it for now. And I think Kiki, jump on in if I'm missing anything, but I think we're pretty much caught up with the questions. I do see a few comments that we certainly, will share with our colleagues in the other areas that work on this.
Thank you. Yeah, I mean, I will give you one other anecdote. In the various states that I've worked in and set a variety of different home and community-based service rates as well as acute care rates, oftentimes the state will say to me at the beginning of the project, we know going in this is payment neutral in the aggregate, but we want to update the methodology to change the benchmark. Just as often, I get the comment, we need to update this methodology because everybody that is still standing here in the department was not around when it was originally set. So we need to understand our own program better. And oh, by the way, the legislature is interested in increasing funding for the service, and they just don't know how or where. And then there was another state I worked in where the predication at the beginning of the project was that, and this was for home and community-based services, that there was going to be a rate increase. And then at the very last minute, the floor fell and the budgeting dropped. So, but we knew what the benchmarks were going to be. And then the providers are like, well, you just came in to cut rates. I'm like, no, I'm not a legislator. I don't appropriate money. I set rates. But I want you, the provider, I think it's important as part of a partnership, particularly in state programs, that at least the providers certainly may not like the rate, let's face it, but they know where they are vis-a-vis where the state would like them to be if that department had the money to pay them. So what is that benchmark? And so I say back to the providers, well, I'm sharing with you transparently, you're at 80% of the benchmark. So you can do the math as well as I, what the difference is and what the ask might be. So, I mean, I've lived through all those scenarios. Obviously, the scenarios where providers get a rate rebase and a rate increase are the most enjoyable for everybody, but sometimes the other ones are necessary as well. So, I'm not naive to know that there's always going to be a rate increase, but most projects don't also walk in saying there's a rate decrease either. It's just more, where do the rates presently stand against said benchmark? Another thing is that oftentimes legislators are saying, well, everybody wants a rate increase. And quite frankly, in some states, it's justified that the providers are all asking for it. But that doesn't mean that everybody, as the secretary was saying, was as far from the benchmark as others. So we would love to fund everybody, but it's almost like get everybody's boat lifted to a certain level. And then if there's still money, we can talk about raising everybody something. But sometimes some folks need a little more help than others because they've been lagging behind longer. So part of this is just to make sure that no provider service category gets so way off course that we've got those that are way behind every year. Like at some point, it'd be nice, everybody, even if it's not to the optimal rate level, everybody's up to a certain level, and then other conversations can occur on funding. So this slide is just an illustration, again, based on our experience as rate setters, that we talk about the cycle, and one could infer that means a year, but oftentimes the process itself, as you saw from my circles of each month, it takes longer than a year. So realistically, we're looking at specifically the rebase categories in the blue boxes. Here's what our experience has been on average, how long the process takes soup to nuts. Again, some take longer and some take less long, depending upon the state and the desire, and sometimes a legislative requirement. But if you think about it, particularly if the service has not been looked at in a long time, and again, oftentimes it's not actually computing the rate, it's the systems work, it's the federal approval, those kind of back end activities. So another piece that the department asked me to look at and to offer up is, besides the roadmap itself, okay, now we're ready to actually start doing these rebases. So what should we be asking ourselves? So I posed 7 questions. There's certainly many more of this, and question 1 might have a 1A, B, C, D, E below it. But if you think of it from a very high level, there's these 7 questions, and I'll touch on each in turn. The first is, which divisions are paying for the service? One thing we've experienced as rate setters is that, particularly in the waiver services or home and community-based services, different divisions in the same department are paying the same providers and paying them in very different ways, and they're competing for each other for that provider pool. So clearly, an understanding of who's actually paying for this is important, because when we start the project, that means all those divisions need to be at the table from the state team. Never mind the providers, but just the state team, we need to think about who needs to be involved. Secondly, as important, what are nearby states paying? In Delaware, clearly we're going to be looking at New Jersey, Maryland, Pennsylvania. So the nuance on this one is that for certain services, again, back to the service definitions, it could be that an example that we've set a rate in from many states has been supported employment, which, people see that term and they generally know what we mean by that. But unless you look at the requirements underneath the service definition in each state, one rate could be 1.5 times the rate of the state next door. People are like, how come we're so different? Well, it could be the service definition that's so different, and the requirements are more. That's why the rate's higher. Or maybe the requirements are the same, and yes, it is 50% more, and that's odd. So we need to kind of be thinking about those types of things in doing a rebase project. Question 3, what data sources? Again, provider costs in a rebase, in my opinion, is always the first stop. But besides the provider's costs, what are other data sources as well? Question 4, are we continuing on with the same methodology? Or is the decision up front, we don't like this methodology, we want something either that has a value-based component in it, it might have incentives in it, you name the buzzword, but it could have different aspects that are not in place today. Or it could be that we generally like the base methodology, but we would like to kind of amp it up and take it to the next level. So we're fine with the methodology generally, but we would like to add that incentive payment or that value-based payment as a layer on top. Next question, how long do we expect it to take? And what might be the limitations, like the systems piece? So we just always advise state clients, make sure your systems people are involved early on. Quite frankly, the systems people don't care as much about the rate itself and the policy. They want to know, how do you want me to price this claim? So that's what's most important to them. And that's what gets them jazzed and sometimes nervous as well. And as a result of that, our systems changes needed. And so that's why I say keep the developers apprised throughout the project, particularly if there's changes. I mean, no project goes linearly exactly how you thought it was going to. There's kind of twists and turns, and letting the systems folks know, well, now we're thinking of doing this modifier. We're thinking of doing this. Well, size, what does that mean? Are we going to add 6 months to the project if we did that? Sometimes that's a decision point. It's not so much the rate itself is like, oh, we're not going to have providers bill this way after all, because it's going to cost the state too much to program it. It's going to be too complicated for the providers to build that way. And then, of course, question 7, what resources does the state need to do the rebase work as well? Who's the lead internally? Do we need other divisions? Do you need outside help? If so, what kind of help? Those types of things. So our recommendation is that, and we're actually offering kind of a template on these 7 questions to the department about, okay, whoever is going to kind of be the project manager from the state leading the project should have this questionnaire ready to start gathering the information at the beginning of the project. They're going to consult with a lot of folks. It's not going to, they can't fill it out themselves probably. So they're going to have to consult with others. And then after they intake that first round of information, that'll help build out a more detailed work plan. So the last item besides this presentation, which is still in draft form, is that we will deliver a final version of the roadmap after hearing from feedback from all of you and whatever other consultation the state gives me on finalizing the roadmap itself. For the key rebase, the blue box services, we were envisioning doing like the 1-page slide that had the months and the steps so that on a single page, anyone could visualize, we believe this is an 18-month project plus or minus, and here's where the steps would fall into place. Separately from that, there could be a more detailed work plan. So that's almost like the recipe of how to go through the rebase project for each of those. It may not be, I mean, many of these are going to be very similar because I outlined the 12 steps. So the 12 steps are going to be in there, but there could be subtle differences depending on the service category that are very important that need to be factored into the work plan as well. The template I just mentioned to help answer the 7 questions. We've also been doing research on the neighboring states' fee schedules for the rate rebase services in particular, and trying to provide wherever possible summaries of the methodology. You know, Maryland pays just like you do Delaware for this service, and they're paying 95% of Medicare and you're paying 97% of Medicare, whatever that might be, but just that kind of little more level of granularity that will help inform future rate rebase projects. And it is also one of our 7 questions about what other states pay. So that concludes what I wanted to talk about with my voice. Now it's time for everybody else to provide questions and comments that either I can answer technically or the state can answer from a policy side.
Yeah, and I guess the last thing I'll just add is I know people have expressed frustration at why this process has taken so long. And really the transparent, candid answer is this was work we probably should have done as a state decades ago. And many of our services, it's because this is an example, I apologize, those who have been on this presentation before have heard this, but for a lot of our rates, Sue in 1985 came up with a process and we've just added an inflator to it ever since. And I apologize, that's not to be flippant or not to say that we don't have the desire to have it be different, but as you can see, both based on the timeline of this process as well as the steps Mark laid out, this is more involved. And those who have lived through and participated in the IDD work, we've had to bring in outside consultants. We've had to have a lot of conversations with the providers. I mean, this is a big change. This is a big change for the state to do this. We were supportive and appreciated the leadership that the JFC co-chairs brought in requesting this. We appreciate the former budget director, Mike Jackson, in saying that this is really where we need to go. And so we embark on it willingly and excitedly, but this is not a light switch process. And unfortunately, this process in and of itself is not going to in lockstep translate into more dollars being made available, but it will set the table and help everybody better understand where we are. And I know it's immensely frustrating to providers to have to cobble together data and to try to get themselves organized to make a JFC presentation. And the hope is that, again, through undertaking this process and getting on a set cadence, that we have transparency around where we are and what the benchmarks are and where we need to go as a state that can keep us all on the same page. And so when there are additional dollars that come forward, there's an understanding of how they will be implemented if they're received and appropriated to the department. So I know we still have a couple questions, but I just wanted to again add that context to the conversation.
All right, so if we're ready for the questions, the one we have that's related to the process would be, how are the outcomes incorporated into the data? Are high performing programs' cost structures weighed more heavily in rate setting? Really good question.
I'll start and I'll ask the department to add in. My experience has been through rebase projects anyway, that really, quite honestly, could be an eighth question. But although I didn't list it as one of the questions, it's certainly always top of my mind in kind of interviewing the state themselves about what are they looking for in the process. Personally, I think the art of the possible should always be considered, i.e., yes, we should be building a rate methodology that not just addresses cost, but addresses quality and outcomes as well. That lends itself easier to some services than others. But personally, I think that every service could have some type of outcome-based or value-based, whatever term of art you want to use, component to it. Some tend to be more sophisticated than others, but by the same token, some states are just like, look, that we agree with you, but we just need to get away from Sue's 1985 rate first and get to a common platform. And then the next go around, we'll talk about the value-based and outcome-based. But I think it's a very good question, should always be considered personally. I don't know if the department wants to add in anything on that, or we'll just go to the next question.
Yeah, Mark, I think so. I think what this person may be alluding to is in the childcare space. We have a joint program with our sister agency, Department of Education, where there's, if you're based on your STARS rating, you're getting some additional payments on top of the purchase of care subsidized childcare rates. So we do have that in existence. And I think it dovetails nicely with your point that there will be some programs for which we say to get at the outcome we want, there's some additional potential funding or incentives that we need to build into the program. So not to say it's off the table for other programs, but I think, you know, as you said so well, it really comes down to what type of outcomes and what are we trying to do? And does that take perhaps, again, some incentives or a different way of subsidizing and providing funding to providers to help
Yeah,
them meet the goals with us.
you saw a little bit of this in the COVID monies that HHS and CMS sent out, where in nursing homes, if they actually, you know, had some outcomes that they were very concerned about, obviously with COVID, they gave them an incentivized grant from HHS. So that's something similar you see from the federal government.
So I think it's not definitely on the table. It's not automatically on the table. It's not automatically off the table. I think it, again, really depends on some of the policy decisions that, again, are not just for the department to make in a vacuum. They're going to involve sister divisions in agencies, excuse me, and they're also going to involve, you know, what's sort of the general ecosystem, like is there federal funding? So it's, again, not an automatic in either direction.
But and the last point is that even if the funding, systems work, whatever it might be, is not there in round one, those conversations need to happen in round one, because oftentimes what we have found with states, they're all excited to do something. It's like, oh, wait a minute, I don't have any source data to base the outcome payment off of, or maybe I have it from some providers but not others, and so I don't want to disenfranchise some because they don't have the data readily available to report on yet. So even if it's setting the stage for year one as a reporting year, and then we're going to implement this in the second year or whatever it takes. But those conversations, you can't just, it's not linear. Like the outcomes based stuff the talks have to happen earlier in the cycle than when you actually implement them, so that everybody's ready and informed about what you're paying off of.
And there's an additional question of where can we find the current benchmarks or rates? And I can field this one very, very briefly, is that the current rates, or at least for the rates as what they were as of last year, are in that study that we referenced at the outset of this presentation. As for benchmarks, that really depends on what we're looking at. So if you're looking for the two areas where we do have, studies out there, those are available on our website, and I can find those links. Or if you want to email me, I can I'll find those links for you. And then the last thing we did have was it's kind of a question and a comment, but I think it is important to note, was about hasn't the pandemic and response created a massive disconnect between costs and the ability to fund? And I think it may be important to note that when this started on this discussion of rates, this was a pre-pandemic world. And so, we are working through all of that. And I don't know if there's really anything else that we'd want to note, but I think, as Mark noted, when he's currently doing rates, he's looking at 2019 rates, because this last year has been very, very challenging, especially for our partner agencies on the line.
But I do appreciate, I think some of the substance use disorder providers are on the call today. And when we did a webinar to go through the cost survey that we're asking them to complete, and many of them have already completed, and I appreciate it, thank you, is one of their comments was, well, we need to characterize the costs pre-COVID and then during COVID, because there's actually been new costs that were not around in 2019. So we added that in. And to be honest, I don't see how any rate rebase project from this point forward does not have to have some question next to it, like how and if do we account for COVID costs when we do the rebase. I don't care what the service is, everybody's been touched in some way. So we just need to ask that question, and it's going to obviously be very specific to each service category.
I saw a question in the chat from Verna. Does this process have to be complete before JFC will appropriate new money? I think that's a question. Obviously, we have a new budget director and a new JFC. I don't know the answer to that. I know we continue to move our piece forward as quickly as possible. I know people don't feel like it moved quickly. For those that remember, in August, I think we were talking about this portion that Mark has already completed. We were saying may not be done until later in the spring. And we worked with Mark and said, what do we have to do to get you to warp the time-space continuum to make it happen sooner? And he did. So we are moving forward as quickly as possible, and staying focused on, even with the pandemic, getting as much done as quickly as we can to move this process along. I honestly don't know. I don't know what decisions the JFC is going to make around how they want to appropriate funding and whether they want to wait for more of this to be done. Obviously, we have the child care market rate and cost of care study going on right now. That's not complete yet, but will be complete before markup, Michelle, we think, or around the time of markup.
I think sooner. I think they're very much hoping to get this through before markup happens.
Yep. And obviously we know, even though, as Thomas put in the chat, the IDD studies almost 3 years old, it was done in 2019, but we do still know where we are with respect to benchmarks. So I've also heard from our home health friends that they don't think it's going to take a huge deal to update the home health rates. So there is nothing in this study that says everybody has to wait until it's done. But the hope of the original epilogue was that this would inform future decisions. So if it's obviously from when it started until now, we've seen some rate increases that have happened. So it's not to say that they have to wait, but we are working quickly because we know that, again, the goal of this was to have this kind of gold standard level of, or not to diminish your work, Mark, I think a lot of states have been here for a while. It's maybe, it's gold standard for us. It's sort of standard for a lot of other states, but we're just trying to get to this level of transparency and predictability around when the state's going to look at rates.
All right, we have a couple of questions also coming in. I'm gonna go out of order, but when will the substance use disorder study be completed?
Well, I am assisting DMA on that. It's funding through the Support Act grant that they received. So they haven't articulated the exact cadence. The survey to providers has been extended now twice to get more responses. I think the plan is to share some information with providers next month. All I can tell you definitively without knowing their calendar is that the Support Act grant ends September 30. So presumably the work will be wrapped up with that.
So, Tom, we can work on getting your response for that one.
Yeah, I do know, understandably, because of COVID, we have struggled to get provider responses, which kind of goes to Mark's 12-step process, and why sometimes this takes longer than we want is it does, these are not light switch processes. We don't want to just set rates in a vacuum. We need to have that level of engagement, and we understand that providers are busy too. And so sometimes the timeline slips, not because both sides don't want to get it done, but just the reality of delivering services, the personnel, everything needed. It just needs, if we're going to work together, sometimes that working together is a little bit of a longer process, but we think it's the right process. Absolutely.
I see there's a question on ACOs and how this relates to the ACO components. This is Stephen Cosentino. I think we all, as you know, that program is an MCO-ACO negotiation, and the ACOs have to create a network and have to negotiate with the network providers on what those rates would be. I think Mark initially mentioned often MCOs use the fee-for-service rate as kind of a their own internal benchmark. Sometimes they do, sometimes they do. Sometimes it's a percentage of that benchmark or that fee-for-service rate. But certainly that's a negotiation that's really in providers' hands and the ACO and the ACO and the MCO. So obviously, I think this work will inform those kind of negotiations. Since right now there is no framework and there is no truly long-term methodology and process. So I actually think this would be a valuable tool that both the MCO, the ACO, and the providers could have in the negotiating process.
Great, I realize that's my cue. There is a question, I think Molly, you may have touched upon this, but before determining to either rebase or update a particular rate, will DHSS determine first if a completely new rate setting methodology be used? So, and Mark, maybe this might be also related to that example of a potential cadence and timing that we were looking at.
Yeah, I mean, as part of step number one, or kind of framing the project, if you will, my experience has been some states, if we're hired, will say, we already know we want to go to X. We don't like what we have. We've talked to stakeholders, or the legislature has told us, or whatever the situation is, they already know where they want to go. It's not up in the air, so to speak. Other states are like, well, we know what we have, but we don't know what we don't have. So can you tell us what else is out there and what are other states doing, or where other states have been successful? So sometimes in that early 6 months of the 24 months rebase is kind of that market intelligence, so to speak. So that's why in the toolkit, we're trying to at least provide wherever methodology is publicly released by states, at least the neighboring states, for these services that are under a rebase. We're trying to do that research for the department so they have that at hand when they're ready to undertake a rebase. So not that it may not change between now and whenever that occurs, but at least there's something versus having to do it all from scratch. So again, I mean, every state's different in how they approach rate setting, but oftentimes the question we are asked is, are we like everybody else, or are we different, or what are the options?
Thank you. There is we had a comment earlier about the need for accountability, and they're wondering if, Mark, if you have seen how states have held themselves accountable for making progress in funding rates once studies have been completed.
So there are some examples, although probably not too many. In oftentimes legislators, if they are given a benchmark, as you know, legislators live on a annual by annual budget themselves, but they kind of lay out their goal that says, we know we can only get to 70% of the benchmark this year, but our intent, not law, but our intent is to get to 75% next year. So, and we are telling you, the department, whoever that department is, when we give you money, they're first in line to get them to 75% next year. So I've seen situations like that. Other states, I mean, they just report the target rate and the adopted rate and the difference, and every time there's a rate update, they just continually show what that delta is. So in a sense, they're holding themselves accountable. That doesn't mean that they're necessarily moving the needle as fast as the providers would like, but at least they're being transparent about where they stand vis-a-vis the benchmark. I mean, as you all know, a lot of this is really at the discretion of those that are controlling the purse strings. So sometimes even the department's hands are tied. And I don't mean just Delaware, I mean collectively state departments that I work with.
Thank you. I don't see anything else outstanding at this time, but so just if I missed something, if someone on the DHS side could catch me. Otherwise, Molly, are you ready to go through what we kind of have as our next steps?
Yep, sounds good.
All right, hold on, let me share.
Big finish. So this is a repeat of what we've already said. I did post the link in the comments. If someone could do that again just before we leave, to what was the initial report that was done. Gosh, it's last year. I keep referring to, I feel like 2020 was just stretching on forever. But that was done before the end of last fiscal year in June of 2020. And then based on, we are going to post this report today. We know is really dense and a lot to walk through. And so we are going to post it so that people can look at it. We would ask that you please submit comments, whether it's on the cadence, you disagree with the example timeline we laid out, you think something needs to be rebased faster, slower, you disagree with the 12-step process, you love the 12-step process, you disagree with the calendar, you love a calendar. Really, any feedback that you have on this roadmap, which again was the key next step that we heard after we did this initial report. We want to hear that so that we can take those comments, see where we can incorporate feedback, and then present a report to the CGO, the JFC, and that final report will also be posted on our website. So obviously we are not done. We still have a ways to go. We understand that for many of our provider partners, they needed money forever ago. And so it continues to be difficult to hear DHSS talk about continued processes. But again, I hope one of the key takeaways you have today is this is a piece of the process. Unfortunately, I wish I had an ability to just generate large sums of money. I think our lives would be a lot easier in a lot of respects if that were the case. But unfortunately, the state is still in a very difficult position of not having enough funding to do all the things that we want to do. So even though we think there's tremendous value in this process, we think there's tremendous value in the transparency that comes from updating rates and services, even if the state can't guarantee that it's going to have money to fund at a benchmark level. Um, we still need the JFC, and we still need revenues in the state to hold up to be able to support any increases. So I know we were happy to get out of FY or get into FY21 without any cuts. And we thank our friends on the federal level for giving the state some stimulus and other funding to do that, including money that went directly to providers. And DHSS worked really hard with people on my team like Michelle Stantz, Stephen Casatino, Kiki Evinger to push money out the door, to advocate for the funding in the first place with the governor, and then to get it out the door to providers. We don't know what's ahead. We are at the beginning of the JFC process. So we still have a lot of DFAC meetings to go. We still have markup to go. So we will look forward, I'm sure, to seeing many of you down, or I guess virtually, with our JFC hearings at the end of this month. But we're going to continue plugging away and look forward to your feedback. And as always, just the incredible work that you all do on behalf of the people that we serve together. So anyone on my team, Mark, anyone else that would like to add any other closing comments? All right, great. Well, again, send to Michelle Stant any feedback. Please put in the subject line the rate methodology study questions or comments, just because as you can imagine, Michelle's getting a lot of email traffic, and just helps her sort and make sure that that we don't misplace any of your valuable feedback. Thank you all so much. Again, just so appreciate all of you and look forward to continuing this work together. Enjoy the rest of your day. Thanks.